Dear Pure Urology viewers, good evening one and all. Today topic is not related to urology surgery, but honestly, an important topic. Sometimes in 6 months or 1 year, we include such a topic that it will be useful for not only urology, for any surgeon. In day-to-day life, in Western countries, the hepatitis, HIV, hepatitis C, hepatitis B, all these things are considered not specific tests before any surgery, because they consider everybody consider as positive and take the precaution. But in India, such type of precautions are not possible. So predominantly this talk will be related to the Indian surgeons who do specifically HIV, HBsAg 1 day before, and most often it is negative and we'll go ahead. But in the present era, some amount of positive cases will be seen, and whether the majority of the surgeons, they say no, I will not do first. Is it correct or not? They say that we will do with additional cost. Is it correct or not? And what are the protocols science recommend? It's not the question of whether you do it or not. Let us listen from one of the very knowledgeable doctor, senior to me in my local area, which I am seeing for last 20 years, meticulously practicing the principles of management of the HIV patients and following them for a long time. Now the job made easy for me that I will refer to sir and then get clearance, and I will do after some time. I know a little bit of theory behind that. Taking that into consideration, I like to introduce Dr. Satyanarayana sir, who has enormous experience as a physician, especially in the field of management of HIV. So this session today is when you detect HIV positive patient, we are confining only to HIV. We are not going to HBsAg and hepatitis C. What to be done before going to urology surgery, whether you detect 1 day before or whether you detect 10 days before or a chronic patient. Dr. M. Satyanarayana is MBBS from Andhra Medical College, Visakhapatnam, 1982 batch. He trained in several reputed institutions like Harvard, USF, John Hopkins in US on HIV/AIDS. His focus of interest is that currently he is the director of Ashwini HIV Care Hyderabad, founder secretary of IMA Kukatpalli, the place where I live in Hyderabad, immediate president IMA Kukatpalli, Hyderabad. He gives best HIV caregiving practitioner in private sector by Telangana AIDS Control Society by Government of Telangana in 2022. He was awarded. Committed to cater the basic healthcare needs of individual in the community with comprehensive family Medicare for the last 38 years. The founder life member of AIDS Society of India, National Faculty AIDS Society of India, providing dependable healthcare to people living with HIV/AIDS in remote rural areas of Telangana and AP states. Conducting several knowledge awareness programs on HIV/AIDS in electronic and social media to reduce the stigma on HIV patients in the community. Providing diabetic and cardiac care under one roof with affordable cost to the needy. More than this, he was my guru in the initial days of my practice, showing the path how to do a private practice, as well as guidelines how the patient can be taken care. We worked many years solving the local problems of the doctors when they are in emergency. That culture is built by our seniors. With this, I hand over the program to Satyanarayana sir. Thank you once again, sir, for accepting the invitation.
Thank you, Dr. Chandramohan, for your kind introduction. Thank you very much.
Yes, sir. Your screen is visible, sir.
So shall I start with your permission?
Yes, sir. Please, sir. You take your own time, sir. This is a live recording watched by the urologists across the world. As a matter of fact, the link will be there same after the talk also forever, so that it will be a very useful YouTube video for our pure urology, sir. Please.
Thank you. Thank you very much. Good evening to all the urologists attending this Zoom meet in this evening. At the outset, I thank Dr. Chandramohan of Priti Urology Center for giving me this opportunity to talk on HIV positive patient, what to be done before going to urology surgery. As a matter of fact, any surgery. It is altogether a new topic probably for all you people exclusively involved in the urological work. We are going to discuss a very important practical points during today's talk and day-to-day OT practice. Please bear with me if I take a little bit more time. In the coming 30 to 40 minutes or so, I'm going to present this issue of a paramount importance to medical fraternity, whether you treat HIV or not. First of all, let us know different statistical facts about the people living with HIV in India. This gives us not only an understanding how much concern really we need to show while dealing with HIV positive case in our day-to-day clinical practice, but sometimes it relieves our apprehensions and misconceptions to a larger extent. In our country today, as of now, 24.7 lakh people are living with HIV. Out of these 24.7 lakh, 19.5 lakh, that is about 79%, knew their HIV positive status. That means rest of the people they didn't know. They don't know. Out of this 19.5 lakh who knew their status, 16.8 lakh, that is 86% are on antiretroviral treatment, that is ART. Out of these 16.8 lakh people who are receiving ART, 15.6 lakh, that is 93% are virologically suppressed. That means in their blood, no measurable or detectable virus is present. That is called as, in our terms, it is undetectable or below detectable or target not detectable. In these people, there is no risk. There is no risk or a zero risk of transmission to other persons from them, either sexually or by occupational exposure. I hope you understood this. So, in the majority of section of the HIV people present in our society at this present day times, so majority people are non-infectious to others, either sexually or by occupation. So this is the term nowadays very popular. U is equal to U. Undetectable is untransmittable. It is a message proactively used in HIV campaigns everywhere in the world nowadays. It means that if someone has an undetectable viral load, they can't sexually or through occupationally transmit HIV to others. U equal to U is supported by numerous health groups and organizations worldwide like World Health Organization, CDC, Center for Disease Control, etc. The validity of U equal to U has been proven through many clinical trials involving thousands of couples in the last 1 or 2 decades time. This is what CDC and WHO says. In HIV-infected population, the green signal is on. That means the green signal is on. That means they are undetectable and there is no measurable virus in their blood. Hence, there is a zero risk or no risk of transmission to their sexual partners, so they can as well go with a condomless sex. Very recently, in 2023 or so, the British HIV Association, in their guidelines, they said that even occupational exposure to HIV through a needle prick injury or a mucosal splash injury will not transmit the virus if the patient HIV viral load is undetectable. Hence, post-exposure prophylaxis is not recommended in this category of HIV positive patients. Recently, one of our colleagues in HIV treating physician in India from Pune, Dr. Sanjay Pujari, has produced a film basing on this U is equal to U concept. This is a pocket film produced by with a title called U is equal to me. U means HIV infected and me means HIV not infected. Let us look at the different scenarios we will face day-to-day surgical practice or a medical practice. So before contemplating any surgery, naturally we will go for a viral screen. Viral screen means it includes HIV, hepatitis B, and hepatitis C. This screen is mandatory for every procedure or surgery, as Dr. Chandramohan has earlier, just few minutes back, he told. In this, if the patient is non-reactive for HIV or any B or C, we will proceed with surgery as usual. But we will discuss three scenarios with the context of HIV status. If the patient is a known case of HIV and already on antiretroviral treatment, that is ART, get a fresh plasma viral load done if it is possible. Try to get the report at the earliest. If the plasma viral load is undetectable, proceed for surgery as like in any other non-HIV subject. In the scenario 2 case, if the patient is reactive for HIV and not on antiretroviral therapy, if it is not an emergency surgery, and if you can wait for 6 to 8 weeks period, refer to a retroviral specialist for initiation of ART in order to achieve undetectable viral. Usually, to make the patient undetectable, it will take 6 to 8 weeks of time in the present day highly effective antiretrovirals. So get a PV plasma viral load done after 6 to 8 weeks. If the plasma viral load is undetectable, proceed for surgery as like in any other non-HIV scenario. Coming to the third scenario. If the patient is reactive for HIV and not an antiretroviral treatment, by the time we are contemplating a surgery, if it is not an emergency and cannot wait for, if it is an emergency and patient can't wait for 6 to 8 weeks, we have to immediately go for surgery. Means you can as well proceed to surgery by taking all the universal precautions as a team. So we are now going to discuss what are all the precautions, what are the steps in different aspects. In this coming 30-35 minutes, we are going to discuss in the scenario of patient is positive, not on the treatment, viral load is high. So first, let us have a look at the definition given by Central for Disease Control to Healthcare Personnel. All persons, whether they are paid or unpaid, working in healthcare settings, who have a potential risk for exposure to highly infectious materials such as blood, semen, vaginal secretions, and relatively very less infectious body fluids like urine, ascitic, amniotic fluid are all called healthcare personnel. So, who are the healthcare personnel in our clinical practice? Usually, most of the healthcare personnel involves in physicians, surgeons, dentists, nurses, OT staff, and paramedicals, laboratory personnel, of course, medical students and interns, and housekeeping personnel and maintenance staff are also not an exception. So here I would like to reiterate one important thing is all occupational exposure to HIV should be considered as medical emergencies and treated immediately and should be treated immediately. So let us see here exposure to HIV is categorized into two different classes. One is occupational and the other one is non-occupational. Now our concern is about occupational exposure. Occupational exposure happens in three ways. One is percutaneous injury. Second one is mucous membrane contact. Third one is non-intact skin contact. So other one, it is not, of course, under our purview right now. It is a non-exposure exposure. It covers sexual, IV drug abuse, blood transfusions, and mother to child. How does an occupational exposure occur? Let us see. It occurs through mainly three different routes. The occupational exposure occurs. Those are percutaneous injury, mucocutaneous, which is the most common form. And next one is the mucocutaneous, and third common one is through non-intact skin, which are not very, very common. So percutaneous injury occurs through needle stick or a cut with a sharp, and mucocutaneous injuries occur with eye mucous membrane, conjunctiva, or oronasal mucosal contact, non-intact skin. So non-intact skin exposure occurs through abraded, sharp, inflamed skin or mucous membrane, or an ulcer on an open wound. So here we have to know that a sustained intact skin contact with virus or inhalation of blood aerosol usually will not transmit HIV. So now let us discuss the transmission risk to HIV to healthcare personnel under different headings. Who is at risk? What is the risk amount? What are the factors that influence the risk? How can the risk can be minimized? And what is the role of antiretrovirals in reducing that? Under these different category headings, we are going to discuss today's topic in detail. So going to the history, we will see some statistics available with CDC for HIV occupational exposures. Whatever the data available, it is all from USA. So India, the data preservation technology and preservation facilities, we didn't have much data to our credit. So all the data we'll get from USA only. So no documented cases, even in US after 2013, updated guidelines of occupational exposure from CDC. Perhaps the reason may be there are no established cases of transmission reported. So these are the occupational HIV transmission is extremely rare. Till date, there are only 58 cases of occupational HIV transmission to healthcare personnel have been reported to US in the CDC. The source is mostly blood, and another in the laboratory, and one is visible blood in the body fluids, and one unspecified body fluid. So this table shows the documented number of various healthcare workers acquired HIV infection through occupational exposure reported to CDC. Nurses and laboratory technicians are the most worst affected category of healthcare personnel. This pie chart shows a total of 58 cases reported to CDC with an occupational exposure. 48 infected are infected. In this pie chart shows a total number of 58. Out of this, 48 infected healthcare persons sustained 49 percutaneous exposures. One worker sustained twice, then the count has become 49. And two other healthcare personnel had a concurrent percutaneous and mucocutaneous exposures. 5 healthcare personnel had a mucocutaneous exposures. 2 workers had an unknown route of exposure. One of them handled the concentrated HIV. So this pie diagram shows the 48 documented cases of HIV infection resulting from percutaneous injury, as shown in the previous slide. The various types of sharp objects implicated are shown in this pie chart. The largest portion represents the hollow bore needles, that is 88%. That is shown in yellow here. The other sharp instruments represented in this chart include the scalpels, 4%, and in green, and the broken wires, 4% in the orange, and the blue slice represent 4% case where the sharp object causing the injury was another is unknown. Please remember that solid needles, that is what solid needles we use in our surgical practice, are suture needles. They do not transmit HIV, but not in the case of hepatitis B. We have to remember this point here. Hepatitis B virus survives on the surfaces for very, very longer periods. Sometimes months together also, hepatitis B virus survives on the surfaces. This table shows the relative risk of transmission through needle stick injury. Among the needle stick injury, hepatitis B and hepatitis C and HIVs are mentioned here. HIV transmission risk through needle stick injury is the lowest when we compare with hepatitis B and hepatitis C viruses. 3 out of 10 percutaneous exposures could result in HIV transmissions when compared to 320 with HBV and HCV respectively. It means hepatitis B is 100 times more riskier for transmission when compared to HIV. This point we have to make it a note and take it very seriously that we should bother more about hepatitis B rather than HIV. This table shows different exposure routes and their transmission efficiencies. Needle stick injury is 0.3%. Mucocutaneous exposure risk is still less, that is 0.9%. Sexual contact risk varies from 0.18 to 1% depending upon the type of intercourse, whether it is vaginal, anal, or oral. So we can make out the risk of occupational transmissions is relatively quite low from this table. We will later discuss what are the factors contributing to increased transmission rates in our later slides. This picture tells about a different body fluids which can transmit the virus and can be classified into basically primarily 3 categories. Category 1 is high risk fluids. Those are blood, vaginal, and prostatic secretions, breast milk. Category 2 is mild to moderate risk. Those are CSF, ascitic, and pericardial, pleural, and amniotic fluids will come under this category. Category 3 is extremely low risk fluids, unless they are contaminated with visible blood. Urine, feces, saliva, sputum, sweat, tears will come under this category. One should remember that these fluids are potential source for other nosocomial and community-acquired infections also. Now, let us see the factors influencing the risk of transmission in this slide. Several factors will influence the degree of risk of transmission in healthcare settings. Those are depth of injury, device visibly contaminated with blood, procedure involving a needle placed in an artery or vein, type of the needle, either it is a hollow bore or solid needle, and size of the needle, it is a IV needle or insulin needle or IM needle, source of the patient's viral load, it is under detectable or a high advanced disease with millions of viral load per copies per ml, quantity of blood exposed, a minimal quantity or a significantly high quantity present in the IV bore needle, duration of exposure, how much time the needle was kept in the vein, immune status of the healthcare personnel, use of antiretrovirus by the HIV infected. So, source patient viral load is also very important. Here we discuss that U is equal to U. So, when the viral load is more, and in case the patient is not under treatment, is terminally ill, viral loads will be very high, then the transmission risk is very high. As we discussed in the beginning, below detectable viral loads will have no risk or a zero risk transmission through occupational sexual groups. More the quantity of blood exposed from injuries or from a hollow bore IV needles, the risk is more. More the duration of exposure to source material, more the duration in minutes, then the risk will be relatively high. So this is the important message. Everybody must keep it in their minds that occupational exposure is considered as an urgent medical concern and it should be managed immediately after a possible occupational exposure. The sooner the better and every hour counts, because if in occupational exposures we want to treat with a post-exposure prophylaxis, means it should be treated on a warful basis. This slide shows the principles of occupational exposure management under 3 headings. So one is immediate wound management, second one is a risk assessment, third one is a counseling and post-exposure prophylaxis and follow-up of the healthcare professional. And coming to the risk assessment, we have to discuss under different subheadings like type and severity of exposure, source patient infectious status, whether it is an advanced or untreated HIV disease with acute opportunistic infections, so whether the patient, source patient is on antiretroviral treatment or not. Once the exposure does occur, what are the immediate measures we have to implement? The first thing is to be done is use a soap and water to wash the wound or exposed skin. Flush the exposed mucous membrane with ample of water. Irrigate the open wounds with sterile normal saline or disinfectant like 10% powdered in iodine solution. I should be irrigated with a clean water or saline eye irrigates. Avoid applying topical antiseptics. Avoid squeezing of the wound. Remember, don't dress the wound. As like in dog bites also, usually any viral infection bites, we don't dress the wound. Report to the concerned authority in the emergency room for an expert advice. Once the injury occurred or an exposure occurred, how do we do a baseline workup of the exposed healthcare personnel? First, rule out and confirm that the particular healthcare personnel is already not suffering from HIV infection. This is very, very important. Otherwise, if healthcare personnel is already harbors a virus by that time, he may claim or he or she may claim that he got infected with occupational exposure. So we should know the current medications of healthcare professional to know the drug-drug interactions with the giving. We are going to give antiretroviral treatments prescribed for post-exposure prophylaxis. Underlying comorbid conditions like renal, hepatic ailments may necessitate ARV dosage modification. That also we have to see. How can we prevent bloodborne virus transmissions? It is only through universal precautions. Hence, they are must for every procedure or intervention. Presume that every patient is HIV, HBV, and HCV positive, as Dr. Chandramohan just now mentioned, unless otherwise proved. And take universal precautions for every patient, irrespective of their serological status, even though some limitations like cost factors are there. Country like ours, so it is not always possible to take all the universal precautions for all the patients. So you have to decide in case-to-case basis in that scenario. So routine HIV, hepatitis B virus, hepatitis C virus screening for all the patients for urological interventions is mandatory. So what are the universal precautions? So universal precautions are control measures that prevent exposure to or reduce the exposure or the risk of transmission of pathogenic agents like HIV. It includes educating and training of the healthcare personnel, use of personal protection equipment, PPE, such as gloves, gowns, masks, goggles, caps, etc. So The second part of universal precautions is, so these are some of the tips we have to observe. Be careful when handling and disposing of needles and sharp instruments during and after surgery. Employing safe work practices like washing of hands and other skin surfaces with soap and water immediately after contact with blood or body fluids. Safe disposal of the waste contaminated with blood and blood fluids. Proper disinfection and sterilization methods. Proper handling of soil. These all comes under different universal precautions. So washing of hands before and after every surgical procedure is mandatory. You know that. Universal precautions sometimes can't replace the routine infection control measures such as hand wash. Thorough hand wash with soap under running tap water and scrubbing of the hand with betadine before and after any procedure is mandatory, as all of you know. What to wear prior to a surgery where the HIV in the HIV or the HIV patient where the viral loads are detectable. What? So this is like astronaut. You have to wear a cap, face mask, so whatnot. Whatever the possible things which will prevent the exposure, you have to wear. Just like an astronaut, you have to go for a surgery. So as we said, you always wear a cap, face mask, gown, goggles for every procedure or intervention. It is sometimes better to use all well-fitted double gloves for extra protection. So how to reduce the risk of exposure? So these are some of the points we have to follow, like reduce unnecessary invasive procedures. Sometimes skill and expertise in doing interventions will reduce the risk of exposure. Take care of procedures such as take care during procedures such as cystoscopy. You do that electro-rhinoscopy, RIRS, where the splattering of irrigated fluids is much more anticipated. Transport of blood and tissue samples in sealed and puncture-proof containers, we have to carefully do that. Coming to a point, use of gloves. Gloves, few points we have to remember. Use sterile gloves. Sterile gloves for procedures involving contact with sterile areas of the body. Otherwise, always using sterile gloves is not necessary. Use examination gloves when anticipating contact with blood and body fluids and procedures involving contact with mucous membranes. Diagnostic procedures do not require sterile gloves. There is no need to use sterile gloves while changing the IV lines or even during phlebotomies. This is for nursing staff and phlebotomies. There is no need to use a sterile gloves always. No need of gloves for routine physical examination of intact skin of HIV infected. We see several doctors, they wear gloves while physical examination for HIV patient. Not necessary. Gloves should be changed between patient to patient examination. This we will know. So gloves reduces the incidence of contamination of hands, but they can't prevent penetrative injuries inflicted by needles and sharp because they are made up of latex and rubber. So penetrative piercing needles and scalpels will go through. So do not disinfect. What our routine practice is, we put some. After wearing gloves, we clean the hands with spirit. That is not correct. Do not disinfect surgical gloves with spirit or other disinfectants. They may cause wicking, which facilitates the penetration of body fluids through the undetected force formed from the on the gloves with the alcohol and all. Always use high quality latex or vinyl gloves. Better to wear well-fitted double gloves. So you have to wear a correct size double gloves while doing surgeries. on HIV positive patients whose viral loads are detected. So a few points about the utility glove. So utility or general purpose household gloves should be used for cleaning floors that housekeeping personnel use usually. They clean floors, they clean instruments while they're handling the garbage and other waste materials. So utility gloves may work. There are some good surgical practices. You may already know them probably. Better to adopt in operation theaters. So here I list some of them. Use safety devices to prevent needle stick injuries. Use intermittent trays for transferring of sharps. Don't transfer the sharps like scalpel blades and all through hand, through a tray. Usually intermittent trays transfer from surgeon to nurse and all. Do not roam around in the OT with sharps in hand. Do not suture wounds from both the sides. Sometimes some practice we see in the OTs to quickly finish the suturing job. Two surgeons will suture the wounds from the two sides. It's not a good practice. Dispose the sharps and using needles in puncture-proof containers. Reduce unnecessary blood transfusions, platelet transfusions, IV injections, and other interventions. That also gives more scope for an occupational exposure. Here, it's a very important point you have to note while recapping the needles. Do not recap the needles by using both the hands. So if you do that like that, there is a risk of piercing the skin with the needle. So do not recap never. So while doing the needle prick injury, risk is very, very high. Do not bend or break or manipulate by using needles by hand at any cost. Place the used disposable syringes, needles, scalpel blades, and other sharps in puncture-resistant containers and dispose of them. So, recapping should not be done. Then, how to recap? This picture shows how to recap the needles. So, this is a correct and safer way of recapping the needle. Recap like this. So use a needle cutter. That is the best way. Don't, instead of recapping it, if you cut it and dispose it off, it is better. So coming to the antiseptics, that is routinely used to disinfect the floors in OTs and instruments and all. So these are the list of antiseptics and disinfectants effective against hepatitis B, hepatitis C, and HIV. HIV is an extremely fragile virus, unlike hepatitis B. So already we discussed and mentioned that hepatitis B is a very hard virus to die. It can survive. The HIV virus can't survive outside the host for a few minutes, but hepatitis B can survive for sometimes months to weeks to months together. But HIV virus can be easily destroyed if it is outside the environment other than the blood for a few minutes time. So these are the antiseptics. This is undiluted citronide. That is this is the antiseptic through which only hepatitis B, hepatitis C, and HIV can be killed. So don't dilute the Savalon. So we have to use the Savalon undiluted form, chlorhexidine, and 2% glutaraldehyde. Household bleach. Household bleach is we commonly called as sodium hypochlorite. 1 in 1,000, I think sodium hypochlorite is household bleach. And as you all know that 40% formaldehyde is formalin, 10% iodine, and isopropyl alcohol contains 70% ethanol. And Dettol solution is not a very effective disinfectant for HIV, hepatitis B, and hepatitis C. These are the different antiseptics routinely we use in our OTs for disinfection of the surfaces, instruments, etc., etc. So coming to whenever a fill, this is a routine happening in our OTs. So when a blood spill or a fluid spill flow comes on the floor, what we have to do? So put a blotting paper. So managing a spill is the best thing is a ordinary newspaper. Put a newspaper, that is the best blotting paper. So after that, for a germicide, that is household bleach. One is 100 solution of sodium hypochlorite is a household bleach. So you put the bleach solution on the spill and wipe the surface with water. Then while use the utility gloves while wiping. So these are some of the special situations which we encounter in day-to-day hospital healthcare settings. So how to clean these things? Soiled linen. Soiled linen, we have to usually give it to laundry, and we will do a machine wash, and in high degree temperatures they wash. That is normal one. Suction fluid and other bulky body fluids during the urological procedure. So you just pour down into a drain through a pipe and all. So that can be eliminated with that like that. So hemodialyzers, how to clean? Never clean the hemodialyzers. Hemodialyzers you try to reuse. So the reuse, when the recycle the hemodialyzers, then the cleaning aspect will come. Try to avoid reuse of dialyzers and tubings. Cystoscopes, ultroscopes, and other urological equipment, you know that we have to keep it in Sidex usually for a specified period. The period duration is also very important. We have to know it from the manufacturer's instructions. As per the manufacturer's instructions only, we have to keep all these instruments for a specific period in the Sidex solution. Now coming to the post-exposure prophylaxis. So injuries happen. Then what we have to do? So first thing is we have to reassure the healthcare personnel. First, before going to that, let us see what is post-exposure prophylaxis. The term post-exposure prophylaxis means that usually we say PEP, PEP, refers to the prophylactic use of antiretroviral medications to prevent the establishment of HIV infection in healthcare personnel after an occupational exposure to HIV. So these are the guidelines what CDC says in implementing for a post-exposure. So here, how to take a decision whether to initiate post-exposure prophylaxis or not. So the benefit of post-exposure prophylaxis, we have to see two factors: risk of transmission. It must overweigh the risk of adverse effects. Then only post-exposure prophylaxis should be advocated. So after hearing all these things, we all know by this time that the great majority of occupational exposures may not result in transmission of HIV. Please remember, if the risk reduction by giving post-exposure prophylaxis overweighs the risk of safety, tolerability, drug interactions, efficacy of the drugs, and toxicity, then PEP can be reached. Otherwise, no. If PEP is offered, the post-exposure prophylaxis, if we offer and initiate it, and the source, if we test the source or source patient later determined to be HIV negative, post-exposure prophylaxis should be discontinued in the healthcare personnel, and no further HIV follow-up testing should be done. So here there are few important cautioning points about the PEP is, so don't advise PEP when it is not warranted. So post-exposure prophylaxis is not justified for exposures with negligible risk. Advise antiretrovirals only after confirmation of HIV transmission risk. So here source patient means through which patient we got an occupational exposure, then the source patient has to be tested immediately. HIV screening of the source patient facilitates to take timely decision whether we have to start post-exposure prophylaxis to the healthcare personnel. So here, what type of test we have to advocate? Use a fourth generation combination antigen antibody kits, that is called HIV combo kits, for rapid and accurate results. Nowadays, the window periods with previous third and second generation kits, the window period used to be 12 weeks. Now with the recent fourth generation kits with 324 antigen, so the window period has become less to 6 weeks. Sometimes we should not care for the window period. Even without window period, we have to get a fourth generation combination antigen antibody test has to be done to the source patient immediately to know the status of the source patient. So if there is a strong suspicion, don't ignore the window period. PEP should not be delayed while waiting for the test. So if there is a great clinical suspicion that the source patient is HIV positive, irrespective of the test report, we have to start the post-exposure prophylaxis. So how much time we have to give and what is the time we have to start? Start post-exposure prophylaxis as soon as possible after exposure, preferably 1 to 2 hours, up to 72 hours only. Once after 72 hours, there is no use of giving the PEP. So the PEP is less likely to be effective if initiated after 72 hours. If source patient HIV status is unknown, then decide on case-to-case basis depending upon the clinical scenario of the source patient. So sometimes we have to consider the background prevalence, that some epidemiological evidence and local epidemiological patterns also. We have to see if there is a chance of having that thing, then we have to decide on case-to-case. Post-exposure prophylaxis should be administered for a full of 28 days if the healthcare personnel tolerates it. This is the flow chart that shows the recommended PEP ratio. So these are the things so we discussed in brief. So once so this is the 28 days course ratio. Recommended drugs are at present nowadays with the clinical data and all, tenofovir, lamivudine, and dolutegravir. So the combination of 3 drugs is a fixed dose cocktail regime. This regime has to be given for all the patients with suspected exposure, and the risk of exposure is there with occupational exposure. This tablet is available in a single tablet. So this is a fixed dose tablet. It should be given for 28 days. So once the PEP treatment started, so post-exposure further testing when should be done. So this test of the healthcare personnel after giving PEP, it should be continued for 28 days, and the serological test should be done at the time of injury baseline. We will anyway do it after 3 and 6 months after. Nowadays, 6 months is not necessary because of the advanced tests like the fourth generation ELISAs. 3 months test is enough nowadays. Use fourth generation antigen antibody kits for immunoassays for earlier and accurate detection. Direct viruses sometimes doing RNA PCR, sometimes not recommended because the sensitivity, specificity of this RNA PCR is low. Role of HIV DNA detector, that is PCR test only, is not very clear. So try to avoid, based more on antigen antibody immunological test with fourth generation. So always psychological impact is very important. So once healthcare personnel affects with the virus, naturally it gives a lot of panic in healthcare personnel. So the psychological impact of exposure to HIV should not be never be underestimated. Every person, every personality, they react in their own different way. So you have to reassure them. Usually, if anybody gets panic Once they know that they are exposed to HIV, reassure them and convince that the risk of transmission is very, very low. Very, very low. It's highly not that very common. It's only 3% with occupational exposure. So counseling is a very important aspect. If required, it should be given to a job, should be given to a counselor, or else you should counsel and ask them to monitor for any symptoms, usually not there, but any symptoms of acute retroviral syndrome, like in first few days or 1 week time, if HIV transmission do occur, they get a flu-like symptoms, rash, lymphadenopathy, etc., and should be brought into the notice of a retroviral specialist. Ask the healthcare practitioner who got an occupational exposure, practice safe such practices of existence for 6 to 8 weeks time till the serology confirms negative for HIV. Sometimes in acute retroviral syndrome, the viral loads are very viremia levels in the exposed is very high, and they may transmit to their partners also. This is called a secondary transmission. To prevent that, we advocate existence for a period of 6 to 8 weeks. Avoid pregnancy during that time. No blood or tissue donation for 3-month period. Explain the side effects and toxicities of antiretroviral medications. Previously, the antiretroviral medication used to be very toxic. Nowadays, present-day drugs like all the present-day antiretrovirals, relatively they are less toxic and they are all well tolerated. Avoid breastfeeding if possible. To attend the follow-up counseling for psychological support and adherence, refer to a counselor and a psychiatric counselor. Take care of the victim as like a small kid. So this is all about the occupational exposure and post-exposure prophylaxis. So ultimately, I'll finish it off. This is the take-home message. There is no or zero risk of occupational exposure with HIV positive case if the positive patient is on antiretroviral treatment and the viral load is if the viral load is below detectable levels, then no post-exposure prophylaxis is required or recommended as per the British HIV Association guidelines. The risk of occupational transmission of HIV is very, very low, only 0.3% compared to hepatitis B. It is 22 to 31%. It is 200 to 300 times more virulent than HIV. Post-exposure prophylaxis is a useful intervention to further reduce the transmission of risk to a negligible, almost practically negligible, and it will not. Failures are not reported in the history. So in future, greater number of needle stick injuries may happen, are expected to happen, and they occur more and more in the OTs if HIV infected patients continue to seek treatment. Please don't see HIV positive patient different from other patients. So sometimes availability of post-exposure prophylaxis should not preclude taking universal precautions. HIV positive status to a patient is not a barrier between a doctor and patient relationship. Always love the HIV infected always, and love the patient and hate the virus. So even if the patient is HIV, is a friend with HIV/AIDS remains a friend always. So keep a look different. Don't have a different look at HIV positive patients. Thank you very much. This is my presentation.
Thank you, sir. Excellent talk. Can you minimize the screen, please, Rajendra? I will ask brief questions, around 5 to 10 questions. Primarily, this may not be everything related to urology. If any hospital admits patient who is HIV negative and after blood transfusion, after 6 months he becomes HIV positive, what is the responsibility of the hospital if he goes to the court of law? Sorry to ask this question, because It's the blood bank responsibility. We don't check all the things. But they say that after coming to your hospital, HIV I became positive, so you are liable. Is it that our blood bank registrations are important, or hospital is also liable? What is basic information? I am not asking the detail.
Sir, actually, before 1998 or 2000, before this thing, the blood banks don't have a strict regimens to do HIV screening for every patient. Every blood where they bleed and
Which year, sir?
1998. From 2004 onwards, the screening of HIV for HIV, hepatitis B, VDRL, and malaria, syphilis, this is made mandatory for blood banks to screen the blood before taking the donor. They screen all the viral screen. I don't know whether all the blood banks are implementing or not. I don't know. But here, one thing is there. When they have to screen and bleed the patient. So take the blood donation. So in case the patient is in the very early period of window period, say first or second week, so the screening test may become negative. So the donor may give blood during the window. That always keep it in mind while donating the donor may be in the window period. If window period is there, means then the virus, that is nowadays strictly all the blood banks are following the things. In the after 2014 or so, having HIV positives, getting HIV from the blood donation, from the donated blood has become very, very low.
Okay, I got the point. The question number 2, sir.
Another thing is who is responsible? There is an act called HIV/AIDS Prevention Act 2017. It was passed in the parliament. So if the patient is in window period and it missed and got the blood HIV acquired through blood, so blood bank is not responsible. It should be proved. That thing has to be proved in the court of law. So if the blood bank didn't do the test and sold the blood of HIV, that is really correct.
Okay, sir. Second thing, I do, after consulting many times you in the initial practice, I have not done, but now I am doing, as you said, HIV patient is friend, is not an enemy, virus is the enemy. I keep one set of endourology instruments exclusive for HIV, just for the sake of confidence for the rest of the population, which is not correct. But is it any logic of having endoscopic equipment separately for HIV? Because the moment you put in SIDEX, it will die. So there is no point segregating. Since continuation of the same question, if I have done first case HBsAg, can I do second case immediately non-HBsAg patient provided all the precautions are taken?
HBsAg is different from HIV, sir. Hepatitis B virus can transmit through an instrument, but in the history, in the CDC registry, even till now, there is a single case is not recorded through HIV transmitted through an instrument, through an endoscope or through a microscope. But hepatitis B, there are several instances.
So people say that you should keep the list at the end of the day. Is it correct? Last case.
HIV, it is not correct. For hepatitis C and hepatitis B, it may be correct.
Okay.
HIV is a very fragile virus, sir. It will die within seconds, within minutes on a surface. So outside
dry. For example, our instruments have inside sometimes scabs of the blood, which are dried up, and after 2 days, if you use this, people say drying up itself is killing the virus. So,
but not hepatitis B, sir. Hepatitis, a blood spot on a wall, if a blood stain on the wall, there is evidence that hepatitis B survived for months together on a blood stains.
My God. So hepatitis B, can it be completely prevented by vaccination? Can you give in one line? For example, I have vaccinated during my MBBS. After that, I vaccinated MS. After that, I vaccinated MCH, but I did not do afterward. If I wanted to go for revaccination, what is the protocol?
Hepatitis B should be prevented effectively through vaccine. The vaccine should be taken three. There are two vaccination regimens. One is a rapid. means 1, 2, 3 every consecutively in 3 months. If it is an emergency, means we have to, because a other partner in the family is hepatitis positive, then we have to be immunized very fast, means 3 vaccines consecutively in 3 months. Otherwise 0 to 6. So month 2, month 6. 3 doses in 6 months, but every 5 years you have to get a booster dose. And another thing,
Not done in the last 5 years, should we take it as a fresh one?
Yeah, only booster dose, only one here. So what we all do a mistake is, so we take the vaccine, take it granted that we got immunized. It's not correct. We have to, after taking 6 to 8 weeks of the vaccine, we have to test the protective titer. So you have to, whether the vaccine has worked.
At least the medical personnel, we have to get it done.
Yeah, important. And another thing, you have to get the anti-HBV, that is the titer. The titer should be 20 units per international units per ml. If you don't achieve the 20 unit mark, you are not protected. Then you have to repeat the vaccine. So
take for hepatitis B. Hepatitis B.
For hepatitis B, after taking vaccine, you have to get the anti-HBV titer done. That is called.
As such, is there any vaccine? Yesterday only I read in newspaper that, I mean, it is all experimental. In our local newspaper that the lot of research is done on the HIV vaccines. Where are we now?
Sir, there is lot of vaccine trials have done in the last 2 decades time. Millions and millions were spent. So there is no active formula or active virus. So still trials are going on, but there is no fruitful trial.
But hepatitis C has na, sir. Hepatitis C has lot of treatment. No?
Treatment is there, but vaccine is not there.
How come hepatitis C treatment has become so good all of a sudden? What treatment is so effective that it prevents even cirrhosis of liver? It prevents the contamination. It prevents, almost they say, curative intent. Is it true?
So this depends upon the immunological ways that hepatitis behave. Hepatitis B is a DNA virus. Hepatitis C is the RNA virus. Hepatitis B and C and HIV, they mix with the genetic material of our cells. So sometimes, hepatitis C, there is a directly acting antivirals. Nowadays, they have come into the market like sofosbuvir and declatasvir. All these newer generation directly acting antivirals. Previously, for hepatitis B, C, interferons used to be given, but they are all very toxic. Even in the urological malignancies, also interferons used to be given for, I think, bladder, CA bladder and all. What I remember.
And one more thing, if any sexual exposure happens, the patient will ask, sir, what is the guarantee that I will not get? If the woman can be traced and do all the 3 tests, if they are undetectable by serological tests, do you say that even HBsAg and hepatitis C, they are safe if their report comes negative for the partner?
So for everything, there is a window period. So
window period, you leave it, sir. I am not going to the window period. That is very unfortunate if it happens. My question is, if the partner is done at day 1 of sex and day 3 months, 6 months, after 6 months also she is negative, do you think that this person is safe? A lot of STD patients ask this. They can have their girlfriend and they can get the test done at 3 months and 6 months also. They may marry also them, as a matter of fact. But what my question is, if they do at first day, 3 months and 6 months, all comes negative, it's 99% safe?
Safe, sir. 99, 100%.
Routine serological test.
Routine serological test means not rapid test. So you have to do
not rapid.
Antigen antibody ELISA test, enzyme-linked immunoassay of 4th generation. They are very sensitive. They are very specific. So all the DNA tests are more specific, more sensitive, less specific. All the immunological, serological tests are more specific, less sensitive. Sometimes, a virus like rhinovirus. Rhinovirus is also a retrovirus. And HIV virus is also a retrovirus. So the genetic structure is sometimes very similar. In DNA test, a common cold virus sometimes may come as a positive.
Yeah. I understand. False positive has to be kept in mind.
Positives are more with DNA. DNA means
RNA.
DNA, RNA. Those are called
DNA, RNA.
RNA.
If anything splashes in your eyes, urine, for urologists, urine sometimes will fall if you don't have specs. Now, though I have specs, I am lucky. If you don't have specs, if they fall in your blood or urine, normally we do is continuously we will wash and check the status of the patient. That's all we do. As you said, the chances is very minimal, 0.3, even less than that. So you need not worry, na?
You need not worry. There is no, in the history till now, with
in the history, it is not reported.
Least means the negligible risk. For negligible risk, even though HIV is positive patients with viral load, with negligible risk, no PrEP is advocated. Means urine, amniotic fluid, feces, sweat, and all these body secretions, even saliva. The saliva itself is a digestive protein and everything will be there. Usually HIV virus is a RNA virus which is made up of protein. So even with the oral sex, HIV will not be transmitted. If HIV positive patient, if they want to have a vaginal sex, they can't afford to do a vaginal sex. We advocate to do a oral sex with HIV.
Oral sex. So it won't be transmitted so easily with oral sex.
In the oral saliva, HIV won't survive because of the proteolytic enzyme. Unless, even if it is a blood stain also, it is difficult to survive.
So why vaginal secretions are so different from the saliva secretions? Is it that vaginal secretions will have more load?
So vaginal secretions will have a more load. Prostatic and vaginal. Actually, the
prostatic secretions also.
Because of the vaginal and prostatic secretions. Because that the virus have a more predilection to grow on those things. That is why HIV is spread through sexual
contact. Probably God has made like that. Anyway, if by chance, if surgeon gets positive HIV in India, can he perform the surgery afterwards without telling anybody? So HPV also, hepatitis C also. I mean, if you know the answer, it's okay. If you don't know the answer, we will pass.
Data means, so you see HCP, healthcare for so we will get a virus, transmission from a patient to healthcare personnel. Sometimes a virus, HIV has transferred from a healthcare personnel to patient. One instance is there, that is a dentist. So that is dentist, from a dentist in US.
From a dentist, patient got.
The patient claimed that I got from a dentist.
Okay.
So surgeon, how can a surgeon can transmit to a patient?
No, that is our prediction. But it's a social stigma. Nobody will reveal, of course. But a theoretical question I am not asking. It's illogical, but theoretical question I'm asking. I know many surgeons who are hepatitis B positive. I know they operate, but I'm not here to dissect on that. Is it that you have to is it that you have to report to medical superintendent or principal of the college? Is it necessary?
No, there like that. And in India also, HIV Act,
they are not treated separately. You are equal rights.
Even if you are HIV positive, you can become a medical professional.
At least tell me that should we inform the wife?
Yeah. So this is a confidential consent. Wife.
So nobody can question your disease, what you have like HIV. They are very personal. When you are asking for consent to do the test, why should they reveal?
Right. So they need not, sir. As per the law, they need
not. As per the law. So that way we are better that we are doing to every patient. In Western countries, they are not doing the test also.
Yeah.
So last question. In our hospital, if the HIV is positive before the surgery, usually I will send to you, you will treat, and after 6 weeks I am operating. Now it is a routine protocol that I am not operating. TURP, URSL, unless it is infection, I am not operating. I am giving the treatment. After that, as you said, U is U, undetectable. you will not get this disease. Fantastic first slide. But my question is, should we inform the wife or anybody? You should not, no question of should we inform the patient and say that you get the treatment, or should we inform the wife or not?
No, only with consent, sir. Consent of the infected person.
So without consent, we should not inform. That is a crime, I think.
Without a consent from the patient, you should
should not inform. The patient can question why you have informed my wife.
Breach of law, HIV Act.
The breach of law, HIV Act.
HIV Act 2017.
So with this, we have crossed 1 hour. So thank you very much, sir. We have conducted, I know you are my well-wisher for the just sake of information. We conducted approximately 300 sessions in the last 4 years. This is started during Corona Pure session. We have 10,000 urologists across the world. Maybe some non-urologists unidentified. Predominantly, we focus on surgical techniques every day. All over the world, all over the surgeons have spoken like this. Only this is the second topic. First, I have spoken on nutrition for the healthcare workers. Second is this, because this is very important related to surgical technique as well. So I must thank once again for, I know you are very knowledgeable. First time I am listening your PPT live. Extremely good. One juniors must learn how 38 years practiced practitioner takes all the crystal clear. No slide has more than 5 sentences. You have finished in 45 minutes. Every slide you named. Your background is clear when you are talking. Your face is also appropriately there in the video cam. They are very important, sir. They are very, very important. I really appreciate. Thank you very much once again.
Thank you very much, Dr. Chandramohan, for your kind remarks. I really always had a lot of respect upon your caliber and your quality. You know, I had always a respect for you in several. So you are my sometimes you are. I'm a fan of you.
Thank you, sir. Thank you very much, sir. With this, we conclude the session, sir.